Okay, good morning, and welcome to Hope Hospice's Family Caregiver Education Series. I'm Debbie Emerson, Hope's community health educator and facilitator of our Family Caregiver Education Series. And not only have I been a health educator for many years, but I've also been a family caregiver. So I always do my presentations from two perspectives, both professional and personal. Over the past 14 years, I've provided care for my mom and her twin sister, as well as my mother and father-in-law. So just a couple of quick comments before I get started. My slides do contain a lot of information. And because of that, because I don't want you to feel like you need to take any notes, my slides are posted on our website. And if you registered prior to yesterday, I sent you an email that contains a link to those slides. In addition, I have an online resource list that contains active links to all of the resources that I used for today's presentation, and actually more. So this is a huge topic, and I wanted to be sure that you had access to additional information should you be interested. Okay, so our agenda for today. I'm going to begin with the philosophy of comfort care and then provide more information about the two categories of comfort care, palliative and hospice, their similarities and their differences. Then we'll look at the family caregiver's role in providing end-of-life care, addressing the emotional, spiritual, and practical issues, including what needs to be done when death occurs. Then I'll talk very briefly about memorial services and pre-need funeral planning. And about halfway through, we'll take a 5-minute break. So let's start by briefly looking at the three goals of medical care. The first one is cure. Now, medical professionals are trained to cure, to fix the problem. And they will offer us all kinds of options from their toolbox that are designed to cure us. Medications, surgeries, and other therapies and treatments. That's their job, and they're skilled at it. So curative medicine is a good thing, but sometimes there is no cure, especially when a person is up there in years, or when a bunch of options have already been tried without much success. Now, the next goal is to stabilize functioning. That is, keep things from getting worse and help the patient to adjust and adapt. So let's say you have osteoarthritis, the type that affects your joints. Now, there's really no cure for this, but with diet and exercise, maybe some medications or herbal supplements, the pain can be managed, and the progression, hopefully, can be slowed. So you can adjust and adapt and learn to live with it. But what if what ails you can't be cured, or even fixed or managed? Then we have to look at the last goal, preparation for a comfortable and dignified death. And this is what we're going to be talking about first today, comfort care, palliative medicine, and hospice services. Again, the similarities and the differences. So hospice and palliative care share the same philosophy of care, the belief that each of us has the right to die pain-free and with dignity, and that our families will receive the necessary support to do so. And also just note that hospice and palliative care also typically share the same professional organizations because there are so many similarities. So because there are so many similarities between palliative and hospice care, it is really easy to get confused. Both are classified as comfort care, and they both involve a team approach to care. But there are differences in eligibility for receiving services, when those services can be rendered, and insurance coverage. Now, hospice care is always palliative, but not all palliative care is hospice care. And hopefully I'll help you to understand that. Okay, so with palliative care, the main eligibility criterion is that the patient and the physician are in agreement that the focus of care needs to move more towards symptom relief and less towards aggressive treatments. More about that in a moment. A person can opt for palliative care at any stage of their illness, whether or not it's considered a terminal illness. And while on palliative care, a patient can still continue with treatments such as radiation or chemotherapy, or even surgeries should they choose to do so. Palliative care is not time limited. In other words, how long the person receives this type of care depends on their needs. Now, most people receive palliative care on an intermittent basis, but this tends to increase over time as their disease progresses. For a patient to be eligible for hospice services, the illness must be considered to be end stage with a life expectancy of 6 months or less. Curative treatments are no longer an option. Now, different states have different requirements for this life expectancy thing. California is 6 months or less. Other states are 12 months or less. And I just want to take a moment to address another really big difference between hospice and palliative care. And that is the emotionality and the discomfort associated with the topic of hospice. Many view hospice as the very last thing to do when death is near, and many don't want to admit that. Some may view hospice as giving up. And I know that this was how my brother and I felt as my mom was nearing the end of her life. By the way, this was a few years before I started working for Hope Hospice and before I truly understood the benefits of bringing in the hospice team. And I'll share our story later on. So the term palliative care seems to be more acceptable. I suspect because the word terminal is not as readily associated with it. And I'm hoping that in the near future, hospice will not carry such a negative connotation, and that people will come to realize that hospice is not so much about giving up, but it's about getting more. All that being said, we do need to have the conversation about end-of-life wishes. How does someone feel about palliative or hospice care should the need arise? This conversation is so much easier if it's done way before anyone needs either of these services. Then it can be handled in a calm, rational manner, as opposed to an emotional one. But the conversation needs to occur, and the sooner the better. Planning what to say and choosing a good time and place for the conversation can help. Individuals always need to feel that they're a part of the conversation and that their wishes will be respected. And no decision regarding palliative care or hospice is permanent. People can always change their minds at any stage of the game. The focus should be on the benefits of stopping painful treatment and hospitalizations. Many people improve on hospice. My aunt, who passed away last year at 102, received hospice services for about 18 months. So when bringing up the topic of end-of-life care, you need to focus on the fact that we're not giving up, but we're looking at adding layers of additional care that greatly improve the quality of life. And it's way easier to have these conversations early at a time when death is not staring us in the face. Now, with the increasing popularity of advanced directives, now they're pretty much a part of any living trust or will. People are considering the topic well before they're in a medical crisis, and this is so good. Okay, palliative care or palliative medicine is actually a relatively new medical specialty that we're seeing more and more. It's estimated that about 80% of large hospitals have a palliative medicine department, and it's a bit less in the smaller healthcare systems. And palliative care sometimes is known as supportive care. So let's take a closer look. So palliative care is an approach to care with a goal of preventing and relieving suffering, regardless of the stage of the disease and regardless of whether it can be cured. Specialists can work with newly diagnosed patients as well as those struggling with the after effects of treatments, such as radiation, surgeries, and chemotherapy. While the main focus is on managing symptoms that cause discomfort to the patient can choose to continue with medical treatment and therapies. And rather than just addressing a patient's medical needs, palliative care addresses physical, emotional, social, and spiritual needs. Palliative specialists are concerned about the whole person, not just the part that's sick. They understand that people with serious illnesses can be frightened and unsure of themselves and may struggle when making medical decisions. The palliative care team works with the patient and the family to respect their goals, their preferences, and their choices. They can help the family to address the many challenges of a serious illness, such as the side effects of treatment, caregiver stress, and fear about the future, what the future may hold. So decisions are made by an interdisciplinary team, and the patient and the family are at the center of this team. The team can help the patient and the family to weigh the pros and cons of various treatments in making those difficult medical decisions, with the understanding that there is not always one right or wrong answer, and that their needs and their wishes may change. So the services are performed in collaboration with the patient's primary care physician and maybe any other specialists that the patient may be seeing. The palliative care team is made up of doctors and nurses who've been trained and who specialize in palliative medicine. And it includes other specially trained professionals, such as social workers, mental health professionals, dietitians, pharmacists, and chaplains to provide spiritual care. It may include other specialists, such as physical, occupational, or speech therapists. So the person's team is going to vary based on their needs and their level of care. And again, just note that, because this is important, at the core of the team are the patient and the family. So when is it time to consider palliative care? Remember, palliative care doesn't mean that the person is giving up on getting better, because they can still receive treatments or even participate in clinical trials should they choose to do so. Palliative means that it's time to focus as much on quality of life as it is on aggressive treatments that may make one feel worse. So a few common reasons for choosing palliative care may include someone who's received a new diagnosis of a life-limiting illness, or when the time comes that a person is relying more and more on others to manage the activities of daily living. In other words, they're no longer able to function independently. Now, hospitalizations are never good, but when a person becomes a frequent flyer, the hospitalization itself can be as damaging as the condition that's sending them there. So kind of a general rule of thumb, if a person has had 3 or more admissions to the hospital with the same symptoms, it may be time to look at palliative care or hospice. Unexplained, unrelenting weight loss may be a good indicator that a person is failing to thrive and that therapies are no longer working. And as I've mentioned, sometimes the treatments and their after effects are worse than the disease. But the bottom line is that when one's quality of life becomes more important than fighting for quantity of life, in other words, more time, then it's time to look for a different approach to care. Here are a few examples of diseases that might lead to a consideration of palliative care. And by the way, this list is by no means complete. So cancers, especially those with metastases, the ones that spread, they tend to be the most common reason. Advanced lung and cardiovascular disease, end-stage kidney disease. Neurodegenerative disease includes Alzheimer's, Parkinson's, and other related dementias. A stroke that has greatly reduced the person's ability to function. And a catastrophic trauma or an injury, such as severe injury to the spine, to the spinal cord, or to the brain. Remember, palliative care is begun at the discretion of the physician and the patient at any time, at any stage of illness, whether it be terminal or not. So a consultation with the primary care physician can help the patient and the family to better understand when palliative care is appropriate and when it might be beneficial. So to begin palliative care, a person's healthcare provider may refer him or her to a palliative care specialist. Now, if their own physician doesn't suggest it, the person can bring it up and ask for a referral. Now, in the past, palliative care teams primarily worked in hospitals, but today we're seeing more services offered through clinics, nursing homes, and assisted living facilities. And just like there are private hospice agencies, we're now seeing private palliative care agencies. And I've included a link on your resource list to a database of providers, both hospital-based and the private ones. So Medicare Part B and Medi-Cal or Medicaid cover the costs of some types of palliative care, but you might have co-pays for some treatments and medications. The same holds true for private plans, which typically cover palliative care, but again, coverage varies by provider and the insurance plan. So check with your health plan to find out what is covered, what's not covered, and whether you're responsible for co-pays, out-of-pocket costs, or other charges. And I just wanted to make a quick mention that Hope Hospice has recently launched a new palliative care service to help patients who are pre-hospice. In other words, they're not quite ready for hospice, to manage their symptoms at home. So when the disease may ultimately progress to the point that the patient becomes eligible for a higher level of care that's provided through the hospice benefit, and if they want to stay with Hope, the transition to our hospice program then will be seamless. So if you're interested in this, you can visit the Hope Hospice website and just click on the palliative care link. Now let's take a look at hospice care. So hospice refers to quality, compassionate care for those facing a life-limiting illness and includes an individual plan of care based on the wishes of patients and their families. The care plan is designed to keep patients comfortable wherever they reside, whether it be their home, a facility such as skilled nursing home, a board and care home, or even the hospital. Hospice is a team approach that includes pain and symptom management and emotional, psychosocial, and spiritual support for patients and their families. So far, this sounds pretty much like palliative care, right? We'll get to some differences in just a minute. Now, more than 90% of people on hospice care are over 65 and have Medicare as their health insurance, either as their primary or their secondary. The costs of hospice are covered 100% by Medicare or Medi-Cal, if that's what the person has, and or private insurance. Now, if someone is under 65 and needs hospice or palliative care, their insurance will cover costs. So if someone is considering this and they're under 65, they're going to need to review their coverage to see if there are any co-pays, deductibles, exclusions, and those types of things. Now, HMOs such as Kaiser also have a hospice benefit, and patients can choose to use either Kaiser's hospice or they can choose another hospice agency that Kaiser has approved. For nonprofit agencies such as Hope, we rely on charitable donations to help fund our services. We're paid by Medicare or Medi-Cal, but it's not enough to cover every expense. But because we're funded by donations, the patients and families on our service will never be charged anything. By the way, Medicare does not pay for room and board associated with hospice care. So if someone is paying out of pocket for a skilled nursing facility, assisted living, or a board and care facility, they're going to continue to doing so, even if the person goes on hospice. Medicare never covers room and board under any circumstances for long-term care. The only exception is the first 100 days in a skilled nursing facility if the person has been discharged from a hospital stay. So included in the hospice benefit are any physician services related to the primary diagnosis. In other words, the diagnosis that made the person eligible for hospice in the first place. Medications related to the primary diagnosis, and also meds for pain and symptom relief. One of the first things the nurse case manager will do is look at all of the patient's medications and determine what's really necessary. Sometimes too many meds can do more harm than good. Now, while the care team will visit and provide services on a regular basis as needed by the patient's condition, the team is available and on call 24/7. Also included is any equipment necessary to keep the patient comfortable. And usually within about 24 hours of the patient's admission to hospice, any necessary durable medical equipment will be delivered to the patient's residence. The medical equipment company will set up everything and, if necessary, show the family how to operate the equipment. Now, the care team will deliver all necessary supplies, including incontinence supplies, dry shampoo, lotions, whatever it is that's necessary to keep the patient comfortable. And then additionally, Medicare patients are entitled to short-term respite care in a Medicare-approved facility, such as a hospital or a nursing home. And so this gives the family caregiver a chance to take a break. And so this is primarily for the hospice patient who is living at home. Your hospice provider will arrange the respite services for you, and the patient can stay up to 5 days each time you get respite care. And you can get this type of care more than once, but you don't want to abuse it, so kind of on an occasional basis. So like palliative care, hospice includes physical, occupational, and/or speech therapies as needed for symptom or pain control, or to enable the individual to maintain basic functional skills and activities of daily living. Again, so far, sounding a lot like palliative care. Now for some differences. Some hospice agencies offer transition programs. And what I mean by this is, like, let's say a person's evaluated for hospice eligibility, but they don't meet the Medicare guidelines. We might put them into a transitional program. At Hope Hospice, we call it advanced illness management. In this case, a nurse or a social worker will check in with the patient or the family about once a month to assess the patient's condition and see if there have been any changes that might indicate hospice placement. Or if someone has been placed on hospice but stabilizes and no longer meets eligibility requirements, the person can be placed in the transition program. I'm going to give you a personal example. About 2 years ago, my 100-year-old aunt was diagnosed with masses in her shoulder and her lung. And at her age and condition, a biopsy to determine if the masses were benign or malignant would not be in her best interests. And what if she did have cancer? There is no way she could have managed chemotherapy, radiation, or surgery. So we placed her on hospice care to focus on comfort and quality of life. About a year later, her condition had not changed at all. She was not losing weight, had no pain, and she was actually doing pretty well. As a result, she was discharged from hospice, but she was placed in the transition program at Hope. Now, towards the end of her life, she developed pneumonia, and the nursing home wanted to transport her to the hospital for treatment. Bad idea. My aunt had dementia and was very disoriented. And the hospitals were starting to fill up with COVID patients at that time. So a very astute paramedic told my cousin that the hospital would be the worst place for her. And besides, she could get breathing treatments in the nursing home. Now, had she been on hospice, the hospice nurses would have handled all of this. And my cousin wouldn't have had to deal with the difficult decision about whether to transport her to the hospital. So the next day, I called our Hope team. Due to the pneumonia, my aunt now qualified to go back on hospice services. By the way, it's not unusual for an elderly person to actually get better on hospice services because they're getting lots of attention and TLC, better medication management, no invasive treatments. So remember that initial hospice eligibility requires that a person has a life expectancy of about 6 months. But as in my aunt's case, benefits may extend well beyond the 6 months if the patient lives longer than expected. Now, my mother-in-law was on hospice for 14 months. My mom, only 3 weeks, because I didn't know better at the time, and I waited until the very end. Now, while palliative care provides emotional support for the patient and the family during the course of the illness, only hospice includes grief counseling for all members of the family for up to 13 months after their death. Okay, this graphic looks just like the palliative care team graphic, but there are some differences. And one of the main differences between the two care teams is that hospice care includes trained volunteers. In fact, Medicare requires that every hospice agency has a certain percentage of volunteers on their service. So volunteers can offer the patients companionship. This is known as a friendly visit. We have some volunteers who sing or play music for the patients and their families. They read to them, sometimes giving the caregiver a little break. We also offer the services of home health aides who are able to bathe patients, help with dining, and in general, do what's needed to keep them comfortable. We also have a registered dietitian on staff who can help with any nutritional needs. Now, another difference is that typically the hospice team and services are managed by a registered nurse case manager, where the palliative care team leader is typically a physician. The hospice medical director, a physician, does play a role on the team, but usually in more of a consultant, kind of an overseer role. Social workers and spiritual care counselors are very involved with the care, and they're also available to help the family however they can. Now, I mentioned in the last slide that hospice also includes grief support for the entire family for 13 months after passing. So a lot of similarities to palliative care, but some very distinct differences. So I just mentioned that Medicare pays for all hospice services. And because Medicare is a government agency, hospice is highly regulated, much more so than palliative care. Medicare's eligibility requirements include that the patient be receiving Medicare Part A, which includes most people over 65. 2 physicians must certify that the patient has a life-limiting illness. Now, one of those physicians can be the hospice medical director. And I'll give you an example of life-limiting illnesses on the next slide. The patient or their healthcare agent, which has either been designated on the Advanced Healthcare Directive or the POST, must sign a consent form that turns over Medicare hospital benefits to the hospice agency. And the patient must receive hospice care from a Medicare-approved provider. Medicare evaluates hospice agencies on a regular basis, and only those who are accredited can receive Medicare funding. And the accreditation process is pretty rigorous. Okay, so here's a list of primary diagnoses to determine hospice eligibility under the Medicare benefit. As you can see, the list is pretty comprehensive. Now, if the patient does not have one of these specific diseases or disorders, yet they are failing to thrive, they're losing weight, and are clearly at the end of life, they can qualify for hospice as long as 2 physicians sign the order. Hospice patients have certain rights, including the right to determine that they want, the right to determine what they want the end of life to look like. They have the right to be informed and participate in their own care as much as they are able to do. Very importantly, they can make the decision to stop hospice care at any time, should they want to pursue aggressive treatment or possibly participate in a clinical trial. And they can resume hospice care at any time when they're ready, as long as they still meet the Medicare eligibility requirements. They have the right to discharge from hospice care when and if their condition improves. And throughout the entire hospice experience, they may continue to be seen by their own physician as long as their physician agrees to follow them, and most do. Now, even though their previous physician may no longer have an active role in their treatment, many patients feel more comfortable knowing that their trusted doc is still with them. Okay, so how do you know when it's time to consider hospice? This is a really hard question because none of us has a crystal ball. But here are some general guidelines. Of course, we're going to look at hospice if death is a strong possibility. If the patient has expressed a desire for a peaceful passing, as opposed to one in the hospital hooked up to a bunch of machines. I think we can all agree that multiple trips to the hospital, repeated infections, refusal to eat meals and take medications, difficulty swallowing, and persistent weight loss do not indicate a quality of life. It may be time to stop the available treatments if they will most likely extend the person's pain and suffering. And lastly, if the patient has expressed a desire to stop aggressive treatment and multiple trips to the hospital. Excuse me. I'll never forget, I'm going to tell you the personal story here. I'll never forget when my mom's physician suggested that it was time for us to consider hospice. I was absolutely stunned. Yes, my mom had been living in a skilled nursing facility for 14 months, and she was 94 years old. Yeah, she'd been hospitalized about 13 times in the past year. She was seeing about 5 different specialists and had several diagnoses, including COPD, she had emphysema, uterine cancer, heart disease, and dementia. And her UTIs were unrelenting. But as her kids, my brother and I were determined that we were not going to give up on my mom. We would get her the best medical care possible, even if that meant repeated hospitalizations and the after effects of treatment. Even if that wasn't what she wanted. She was tired of living and tired of fighting. And honestly, I think she was tired of trying to please my brother and me. It never occurred to us that we were actually being selfish, trying to keep her alive through aggressive medical treatment. We thought we were taking good care of Mom. And we weren't ready to lose her, even though she was so ready to go. So ultimately, we chose to get her evaluated for hospice. And we were shocked when the hospice nurse told us that my mom didn't have much time left. We couldn't see this because we didn't want to see it. We didn't want to accept it. And that nurse was spot on. My mom passed away about 3 weeks later. My only regret is that we didn't consider hospice much earlier. My mom not only got an extra layer of care, but the support my brother and I received during her last weeks of life was unbelievably valuable. And my mom had a good death. That wouldn't have been possible without the hospice team, and in particular, the nurse who was with my mom and our family on the last day of her life. So I'd like to read a quote from the Hope Hospice website. A common misconception about hospice care is that a referral can be premature. Hospice care is the most effective, over a period of months. Yet most hospice patients die within a month of referral based on the reluctance to refer patients earlier or at all. An early referral can provide patients with extra attention and focused hospice care that relieves symptoms and manages pain. It also offers patients and families a vital opportunity to deal with their loss and to say goodbye. Now, our family definitely took that earlier is better advice with both my mother-in-law and my aunt. We're so glad that we did that. So I have mentioned comfort measures for both palliative care and hospice. So what does this term mean? Any diagnostic tests or medical procedures that may do more harm than good are eliminated. Remember, I mentioned that our family chose for my aunt to not endure a lung biopsy when a mass was detected. Hospital stays do more harm than good for elderly patients. And if you've ever been a patient in an intensive care unit or a cardiac care unit, you know how stressful those stays can be. There's no radiation or chemo unless necessary for pain relief. Remember, with hospice, the patient no longer wishes to receive any treatments that may potentially cure their condition. But let's say that a patient has a tumor on his spine that's causing him a great deal of pain. If radiation can shrink the tumor so it's no longer pressing on nerves, then it can certainly be used. Surgery is okay as long as it's done for pain relief and as long as the patient can tolerate it. Now, if they consent and if the hospice agency agrees to do this, the patient can receive antibiotics if needed to treat an infection, such as pneumonia or a UTI. Feeding tubes are generally not used with a hospice patient. In fact, people usually indicate their wishes for a feeding tube on their advanced healthcare directive or their POLST. The only exception is that if a feeding tube is already in place when the patient goes on hospice service, then it can stay in place. So I've mentioned POLST a couple of times. POLST stands for Physician Orders for Life-Sustaining Treatment. Now, these legal documents are used for both palliative and hospice care and are typically completed when someone is seriously ill, if they're entering a care facility, having major surgery, or going on hospice or palliative care. POLST gives specific directions to the medical team so that unwanted or ineffective treatments won't be used, and it ensures that the patient's wishes are honored. So for this form to be considered a legal order, it must be signed by a physician, a nurse practitioner, or a physician assistant, all within their scope of practice. Now, most states have this type of form, but they may have different titles. And each state uses a different color of cardstock to print their forms. In California, we use bright pink. So I just wanted to take a minute to share a bit about this 2-page document. The POLST is much more specific regarding medical care and treatments than is an advance directive, but it doesn't take the place of an advance directive. Make sure that the POLST and the advance directive are aligned, meaning that they support the same goals and the info doesn't conflict. The POLST enables the patient or their healthcare agent or proxy to choose just what type of medical care they want. So let's just look at some of these sections. In Section A, patients indicate if they want CPR or if they do not want to have resuscitation attempted. In other words, they want a natural death to occur. Section B specifies what medical interventions are desired. Now, only one box can be checked. They can choose comfort measures only, which includes anything that relieves pain and makes the patient more comfortable. This includes medication, oxygen, and wound care. Hospitalization is only allowed if comfort needs cannot be met in the current location. Now, the next option in Section B is limited additional interventions. So in addition to the care described in comfort measures only, patients can agree to antibiotics and IV fluids as needed. Intubation is not allowed. And then the last option in this section is called full treatment, which is kind of self-explanatory. And there's a place on here for any additional specifics that the patient desires. Section C is about artificial nutrition, should the person no longer be able to chew or to swallow. Now, the three options include no artificial means of nutrition, including feeding tubes, or a trial period of artificial nutrition, just to kind of see how that works out, or long-term artificial nutrition. And then Section D is for signatures. If the signatures of the patient, if the patient is able, a healthcare representative or proxy, if the patient is not able. And as I mentioned, the form must be signed by a physician, a nurse practitioner, or a physician assistant if it's within their scope of practice to do so. Now, these forms can be revised at any time if a patient changes his or her mind. But each time a new form must be completed, and in order for it to be effective, it has to have that physician signature on it. So just like it's your right to choose a palliative care provider, it's your right to select your hospice provider. Sometimes when a patient is in a hospital or a skilled nursing facility, the staff will recommend a hospice agency, possibly one with whom they've done business or one with whom they have an agreement. Some hospice services are built into healthcare systems such as Sutter, Kaiser, John Muir Health. But ultimately, it's the decision of the patient or the family. It's important that you do your homework when selecting a hospice provider, because not all of them are the same with regard to the quality of services they provide. So for recommendations, you can ask people that you trust. You can use Medicare's Care Compare site to find providers in your area. And I have a link to this site on your resource list. The site also has ratings and evaluations of each agency and gives details about the quality of services they provide. The site indicates whether or not the agency is for profit or not for profit. Now, in my opinion, which is slightly biased because I work for a nonprofit, you'll get more personalized and compassionate care from a nonprofit because they're not a big business and their primary goal is quality patient care, not money making. So always check accreditation and licensure, and you can find this information on the agency's website. Now, Medicare will only list agencies on their Care Compare site that are licensed and Medicare approved. And I included 2 documents on the resource list that can help you should you need to find a hospice provider. Now, while someone can self-refer to hospice, it's usually a family member or their healthcare proxy, a physician, hospital, or care facility that's going to make the referral. By the way, it's always good to talk with the person's primary care physician about the person's suitability for hospice. The physician's going to need to sign the order to get the process going. 2 physician signatures are required, and one of these can be the hospice's medical director. The process is pretty simple. Once an agency has been selected, you can give them a call, or some of them have online forms that you can submit. Now, hospices are used to moving pretty fast. I know that our agency will typically get a nurse out to do an evaluation wherever the patient resides within 24 hours. And once it's determined that the patient's eligible and 2 physicians have signed the order, a nurse case manager will assemble a team and they'll meet with the patient and their family, usually over the course of a couple of days. If medical equipment, such as a hospital bed, bedside commode, wheelchair, whatever, are needed, the nurse will arrange for those to be delivered. Now, that's the easy part. Honestly, I think the hard part is making the decision in the first place to bring in hospice services because it makes you face the reality that you'll soon be losing someone that you love. But if you can view it as ensuring that your loved one can experience the best quality of life possible, I promise you that you won't have any regrets. Now, at least my family didn't. Okay, so I want to take a look at the family's role at the end of life, including providing care and funeral planning. So generally speaking, we need to focus on practical tasks, mental and emotional needs, spiritual issues, and providing physical comfort. And I'll go into more detail in the upcoming slides. And caregivers need care as well during this very emotional and stressful time. And that's one of the great benefits of hospice. We care for the families too. So always remember that you are an important part of the care team. Your area of expertise is your loved one and their needs. And it's your job to serve as an advocate and a spokesperson. So I've included on your resource list a link to a booklet from the National Institute on Aging, one of my favorite resources, favorite booklets. And it's an excellent resource to help families know what to expect and how they can help with comfort care. You can get an online PDF version of this, or if you're one of those people that likes to have it in your hand, I believe they are still allowing you to request a free copy in the mail. So you've heard this before. I'm a big promoter of the importance of advanced planning, both for ourselves and for those we care for. Remember, things are so much easier when we discuss difficult decisions in advance at a time we're not in crisis mode. Now, it goes without saying that every adult should have in place a will or a living trust. An advanced healthcare directive designates a healthcare agent if a person is unable to make their own decisions, but it also outlines the person's wishes for care and treatment at end of life. We talked about Pulse a few slides back, and these documents are usually activated when someone is seriously ill. It's also important to have conversations about one's wishes regarding placement in a facility should the time come when the person can no longer be cared for in their own home. Of course, none of us want to be sent to one of those places, nor do we want to send our loved ones there. But sometimes it really is the best option. Having a realistic and honest discussion about the what ifs can hopefully make these decisions easier when and if the time comes. Now, another consideration, if the person has been residing in a care facility, do you want to, and are you able to, bring them home for that end-of-life hospice care? Remember, they can receive hospice services wherever they reside. Now, some facilities, including some hospitals, have a special wing or rooms for patients who are on comfort care. So my brother was in the intensive care unit at UCSF for the last 3 weeks of his life. He was conscious, but he was on life support. When he made the decision to stop life support, he was moved to the comfort care unit in the hospital, which was much more peaceful than the chaotic ICU. Now, if he'd had more time, the plan was to move him home with hospice care. So in terms of spending time with others, some people who are dying want to see friends and acquaintances, others do not. And this preference can even change from day to day. If you're acting as the gatekeeper for that individual, always ask permission before allowing visitors so you can respect your loved one's wishes as best you can. And keep in mind that talking and visiting can be tiring. So try to gauge your loved one's energy level before allowing visitors. You want to look at how all of this will impact your everyday life. When someone you love is dying, it's perfectly natural to put your normal life on hold. You might want to spend as much time with them as possible and find it hard to think about anything other than helping them through this. You may also feel on high alert when you're away from them, waiting to hear news that you dread. And all of these feelings are normal and natural. So explain as best you can to your family, and your friends, and your coworkers what you're going through. Be sure they know that additional stresses, strains, or demands may be difficult for you to handle right now. And also be honest about what help you might need. People often offer to help, but they don't know what you need. So this is your opportunity to let them know. Pre-need funeral planning enables one to make arrangements for their own funeral or memorial service. For example, things like, do they wish to be buried or cremated? What kind of a service do they want? They want a casket or an urn? My mom even told us what music she wanted, and she instructed me to place her favorite artificial flowers next to the guest book. Um, that wouldn't have been my first choice, but I needed to respect her wishes. By the way, everything can be paid for in advance. Now, this may sound a bit morose, but not only does it give the person complete control, but it's a wonderful gift to give to the ones who will be left behind. It saves them the agony of making these decisions. And again, it's all paid for. It can also prevent a lot of fighting within the family when members have different ideas of what they think is best. And I'll be talking more about funeral arrangements in just a couple of minutes. It's not uncommon for people to avoid these topics. We procrastinate because they're uncomfortable to talk about, and we always think we have more time. So sometimes when we think about end-of-life care, we focus on the physical needs. But complete end-of-life care also includes helping the dying person manage mental and emotional distress. Someone who's near the end of life might understandably feel depressed or anxious or confused. If the person is alert, encouraging conversations about feelings might help. Medications to treat anxiety might also be an option. A dying person may also have some specific fears and concerns. He or she may fear the unknown or worry about those left behind. Some people are afraid of being alone at the very end. And this feeling can be made worse by the understandable reaction of families and friends. For example, when family and friends don't know how to help or don't know what to say, sometimes they stop visiting. It's just too uncomfortable for them. Or someone who's already beginning to grieve may withdraw. All of this can add to a dying person's sense of isolation. So if this is happening, discuss your concerns with family and friends, or if your loved one is on hospice care, the social worker or spiritual care counselor would be excellent resources. So how else can we help our loved ones with all this? The simple act of physical contact can be extremely comforting. Holding hands, a touch, a gentle massage. It can also make a person feel connected to those that they love. It's important to create a comforting environment. This, of course, depends on what the person enjoys. Some people are very social, so it may be natural for them to want to be around family and friends. Others become agitated with too much going on around them. They may be more comfortable with just one or a few visitors. For some people, keeping distracting noises like TVs and radios to a minimum is important. When a person is transitioning, in other words, when death is very near, music at a low volume and soft lighting can be soothing. In fact, near the end of life, music therapy might improve mood, help with relaxation, and lessen pain. Listening to music might also evoke memories that those present can share. Often just being present with a dying person is enough. It may not be necessary to fill the time with talking or activity. Your quiet presence can be a simple and profound gift for both of you. People nearing the end of life may have spiritual needs as well. And this can include searching for meaning in one's life by reflecting on their life's accomplishments, their contributions, important relationships. The person may begin looking at their legacy, what they're leaving for future generations, maybe asking themselves, what have I done to leave this world a better place? The dying person might find peace by resolving unsettled issues with friends or family, saying things that may have gone unsaid. Most people don't want to leave this world feeling regrets. And then, of course, many people find solace in their faith as their life is nearing an end. But on the other hand, others may struggle with their faith or their spiritual beliefs. Praying, talking with someone from one's religious community, reading religious texts, or listening to religious music may bring comfort to those who wish that. Family and friends can talk to the dying person about the importance of their relationship. These days we have the luxury of connecting through FaceTime and Zoom. Sharing memories of good times is another way some people find peace near death. This can be comforting for everyone. And we know that even if a patient is unconscious, there's a good chance that they still may be able to hear. So it's probably never too late to say how you feel or to talk about fond memories. And make sure that you always talk to, not about, the person who's dying. Now, just a note, there may come a time when a dying person who's been confused or even unconscious may suddenly become clear thinking. So take advantage of these moments, but understand that they're probably only temporary. It's not necessarily a sign that he or she is getting better. Sometimes we refer to that as the surge. Sometimes a dying person may appear to see or talk to someone who's not there. So try to resist the temptation to interrupt or say that they're imagining things. Give the dying person the space to experience their own reality. As a person is nearing end of life, the body systems begin to shut down. So as care partners, we need to focus on ways to manage their discomfort. The end of life booklet that I mentioned earlier gives lots of good suggestions for keeping our loved ones comfortable. And I'll just mention some of the more common issues. We tend to see digestive problems such as nausea, vomiting, constipation, loss of appetite at the end of life. The causes and treatments for these symptoms are varied, so check with your hospice nurse or the doctor. Constipation is a common side effect of strong pain medications, especially those that contain opioids. If your loved one's taking morphine to manage pain, they will also most likely need to take a gentle laxative. Now, some people are too tired or weak to eat. Some people have lost their appetite. You may try to gently offer their favorite foods in small amounts, or try serving frequent, smaller meals. But we really don't want to force a person to eat. Going without food and/or water is generally not painful, and eating can actually add to their discomfort. Losing one's appetite is a common and a normal part of dying. Swallowing may also be a problem, especially for people with dementia. Shortness of breath, or the feeling that breathing is difficult, is another common experience at the end of life. So people very near death might have noisy breathing. Sometimes this is called the death rattle. This is caused by fluids collecting in the throat or by the throat muscles relaxing. Now, there's medication that can be prescribed that may help clear this up, or sometimes having the person lie on their side might help. Not all noisy breathing is a death rattle, and it may help to know that this type of breathing is usually not upsetting to the dying person. it tends to be more upsetting to those of us around them. With age, skin naturally becomes drier and more fragile. So it's important to take extra care with an older person's skin. The end of life booklet gives some good suggestions for managing dry skin and preventing painful bed sores or pressure ulcers. Now, the aging process in general causes loss of fat under the skin, and fat is a good insulator for both heat and cold. So the elderly, especially those at the end of life, tend to become more sensitive to changes in temperature. So just because the temperature is comfortable for us doesn't mean it's comfortable for them. People who are dying may not be able to tell us that they're too hot or they're too cold. So watch for clues and be responsive to their needs. By the way, if someone is too cold, avoid electric blankets or electric mattress pads. They can get too hot and cause burns, especially for somebody with fragile skin. The fatigue. It's common for people nearing the end of life to feel tired and have little or no energy. So keep activities simple. Manage visitors so there's plenty of time for naps. And then, of course, there's pain. Watching someone you love die is hard enough, but thinking that that person is also in pain makes it worse. Not everyone who is dying experiences pain, but there are things that you can do to help someone who does. Don't be afraid of giving as much pain medication as is prescribed by the doctor. Care for someone who's dying should focus on relieving pain without worrying about possible long-term problems of drug dependence or abuse. And you probably know that pain is easier to prevent than it is to relieve. And severe pain is very hard to manage. So try to make sure that the level of pain does not get ahead of the pain relieving medicines. Tell the doctor or nurse if the pain is not controlled so that dosages can be adjusted. Okay, I see a question up in the question box. So let me see if that's something that I need to address right now. Okay, I've always wondered if the patients are telling physicians that they're in pain when they start administering pain meds. My dad is not in hospice stage, but he says he's not feeling any pain. So I have mixed thoughts about morphine and wonder when and what signals the pain. Okay, that's actually a really good question. So let me address that right now. So if somebody has dementia, and I don't know what your dad's situation is, but in particular, those who have dementia have a very difficult time expressing pain. And so and a lot of times you'll say, well, are you in pain? Does that hurt? And the response always tends to be no. And so what we as caregivers, and this is true for those with dementia and those without dementia, as caregivers, we need to be looking for other signs, nonverbal signs of pain. We need to look for grimacing. We need to look if somebody is like rubbing a body part. We need to look, at their facial expressions, any kinds of groans or grunting. So just because somebody says no, they're not in pain, it doesn't mean that's necessarily true. Now, the mixed thoughts about morphine and wonder when and what signals the pain. Again, the doctors and the hospice nurses, once the patient is on hospice, are pretty much experts at determining, if the person is experiencing pain, even if the person cannot, articulate that. So they're going to be your best judge on that. Now, with the morphine, one of the concerns that a lot of people have is that the person will be so out of it that they won't be able to communicate or be responsive at the end of life. And as family members, we want to have every possible minute we can with them. So you can always ask the nurse, the goal is to adjust the dose of morphine so that the person is alert, can still communicate, but is not experiencing pain. And sometimes that takes a little bit of trial and error. The person who wrote the question says her dad has both cancer and dementia. And this is so on point what you're saying. Yeah, it's, I've seen that personally. I've seen that also with patients, as, they really can't articulate the pain, or like in the case of my mom, she had dementia as well, but vascular dementia. So she wasn't, most of the time she was okay. But she never wanted to admit that she had pain for whatever reason. She didn't want to feel like, she was a burden, or that, she couldn't take it. So it's tricky. It's tricky. And as family members, we gotta, again, we have to be really in tune with our loved one, and, try to gauge, when they are in pain, and then ask for help from the nurse. Oh, you're very welcome. Okay. Let me close this. Those are great questions, by the way. Okay. So signs of dying. For some people, the dying process might take a few weeks, several months, or even longer. For others, the transition from apparent good health to death might occur swiftly, within days or even hours. Remember, this dying process does not conform to a timetable, nor are there specific signals that indicate exactly how much longer a loved one will have. However, in the elderly and the chronically ill, there are often signs which can begin a month to 3 months prior to death. So understanding and recognizing these signs might help you prepare for your loved one's death. Now, at Hope, we always give the families what we call our little blue book. It's called Gone From My Sight. It's very old, been used forever, but very spot on. So in very simple terms, the book guides you through what to expect in the last couple of months. I remember getting this booklet from my mom's hospice nurse. Now, being one of those people who wants to know everything, control freak, right? It kind of gave me a sense of control over an uncontrollable situation. So I read and reread this booklet and referred to it every time there was a change. And I also made sure that I shared it with my brother and my sister-in-law. Now, another really good resource to help prepare you is an article found on an online site called Very Well Health. The article is called How to Care for a Dying Loved One. Now, I don't have the link to this on that resource list that I gave you that's available, but you can either write down the URL that's up here, or you can just simply Google Very Well Health, How to Care for a Dying Loved One. And then if you aren't able to write this down during this presentation and you want to look at that booklet, just send me an email and I'll send you the link to that. Okay, you might not be ready for this right now, but when the time comes, you may find these resources to be really useful. So regardless of how prepared you think you are, the ultimate passing will still be a shock. I hear so many times, especially from those who are caring for a loved one with dementia, that they've done all their grieving prior to death. Now, it's true, whether our loved one has dementia or some other terminal illness, and we're anticipating death, we start grieving while the person is still alive. We start missing them even before they're gone. We also grieve for other things, such as the loss of our future together. Care partners grieve for the loss of relationships. I know towards the end of her life, I didn't feel as if I had that mother-daughter relationship with my mom anymore. And I really missed that. I grieved that loss. I also grieved for what I had to give up to care for her. My life changed dramatically once I became her care partner. And I suspect a lot of you can relate to that. And then after my mom passed away, I experienced a very different, and I'll admit, unexpected type of grief. The finality of losing her. Oddly enough, even though I am, not a young person, I felt like an orphan. My dad had passed away when I was very young. My mom was my last parent, and it was just a very, very strange feeling. And I've talked with other adult children who've lost a parent, and I've found that that's actually kind of a common feeling. Grief is very, very complicated. And we're doing a webinar on grief and loss in July. So if you're interested in this topic, that might be a good one for you. Now, should there always be someone in the room with a dying person? So it can be comforting for the caregiver to always be there, but it can also be tiring and stressful. So unless your cultural or religious traditions require it, don't feel that you have to stay with the person all the time. If there are other family members or friends around, try taking turns sitting in the room. And some people almost seem to prefer to die alone. They tend to slip away just after visitors leave. My mom did that to me. My father-in-law did that to my mother-in-law. So there's no law, by the way, that says you have to have your loved one's body picked up immediately after death. If it brings you or your others comfort to spend some quiet time saying goodbye, please do so. My mom passed in a care facility, and our hospice nurse took care of all of the final arrangements and then gave my brother and me some time alone with our mom. And when the funeral home staff arrived to take her, my brother wanted to stay in the room, and he wanted to help them prepare my mom for the trip to the mortuary. He needed to feel like, he was a part of that process. Very special to him. And, watching him do so is really something that I'll never forget. Everyone reacts to death differently. My mom's twin sister, who was also there at the care facility with us, chose not to be in the room when my mom passed, nor did she come to the room to say goodbye. For her, the best thing was to remember my mom as she was. I said that grief is complicated, but it's also highly personal. Some of us are very emotional, others tend to be more stoic. This is not a time to judge how others react and respond. It's really a time to respect and accept our differences. Okay, so let's look at some practical guidelines about what to do when death occurs. If the person's in a hospital or a nursing home, the staff will call the funeral home or the mortuary that you have chosen. So just be sure that they have the correct information. We had a near mishap when my father-in-law passed away in a nursing home. So, by the way, what's the difference between a funeral home and a mortuary? Because we tend to use those terms interchangeably. But there's one big difference. Mortuaries usually offer on-site cremation, whereas a funeral home will have to send the body elsewhere to be cremated. If your loved one passes at home or in a long-term care facility while on hospice care, call the hospice staff. Most likely the hospice nurse will be with you for those last hours. The hospice nurse will contact the funeral home. By the way, when you're making the initial arrangements to start hospice services, the social worker will ask if funeral arrangements have been made, and they'll document that in the patient's chart. So if you've not made any arrangements, though, they can give you a list of local options. As always, way better to take care of this before the person passes. Now, if your loved one passes at home and is not on hospice, it's best to call the local police non-emergency number. Now, you can call 911 if you don't have that non-emergency number. Oh, but non-emergency is the best. There's also a fire department non-emergency number. This does not need to be done immediately, should you or your others want some quiet time together. But when you do call, be sure to tell them that death was expected and that your loved one has a DNR and/or a pulse. And be sure to have those documents available. Paramedics are trained to resuscitate unless they see an order to the contrary, or if it's abundantly clear that the person has passed. By the way, DNR laws vary by state, and in some cases, calling the police is not necessary. Instead, you might call the person's physician first to have them declare death. And by the way, this is permissible in California if the physician has seen the patient within 20 days of death. So please share all of this information with any family member or friend who has the potential of being present at time of death, because you don't want to turn an expected event into an emergency situation. So death must be pronounced by someone in authority. So that's a doctor, a hospice nurse, a coroner, a medical examiner. The doctor or the hospice nurse will complete the forms necessary to issue the death certificate, and they must be signed by the attending physician. And then the funeral home will arrange for the official death certificate from the state. So you're going to need to tell the funeral director how many copies of the death certificate you will need. Your loved one's financial and legal circumstances will determine this. So it just, again, depends on how complicated their financial situation is. Now, most people I've talked with say that 10 is the minimum number. There are some places that will accept a photocopy, but banks, other financial institutions, life insurance companies, etc., need to have the actual original official document. By the way, Social Security and Medicare are automatically notified when the death certificate is filed. And if you run out of death certificates, you can always just go to your county's records office and get additional copies. Now, the physician will determine if an autopsy is necessary. If death was expected and the person was on hospice or had been seen regularly by a physician, an autopsy is not usually necessary. So always be sure that everyone, the physician, the care facility, and hospice, is aware of any cultural or religious issues surrounding end-of-life arrangements. Now, the elderly or chronically ill don't usually donate organs. However, if the person had Alzheimer's or a related dementia, the family may choose to donate the brain for research purposes. Very individual. Okay, so I'd like to share some tips about funeral planning that I've picked up either through personal experience or through some of my research. It's really important that you wait to give any information about services to family and friends until all the details have been confirmed, either with the funeral director, the church, the clergy, whomever. This is going to save you much time should details change. And these days, with everybody posting everything on social media, waiting until all the details have been confirmed can save a lot of confusion if someone happens to post the wrong information. Funerals are ridiculously expensive. Now, depending on what services are desired, they can range from $3,000, $6,000 to $10,000 and up. And remember, we're making arrangements at a time when we are already exhausted and emotionally vulnerable. So it's not a great time for making sound decisions. And sadly, some businesses will take advantage of us during these challenging times when we may have a tendency to overspend as a result of being emotionally fragile. So making arrangements in advance allows us to compare prices, review facilities, and select the services and merchandise we want at a time when we're thinking more clearly. I know my husband and I, even though we're both really healthy and not close to death, we've already taken care of that, and we have pre-need funeral arrangements because we don't want our kids to have to worry about any of this when the time comes. Okay, so compare prices from at least 2 funeral homes. The law requires that funeral homes give you written price lists for products and services, and resist the pressure to buy goods and services that you don't really want or need. Honestly, you really don't need to have the fanciest casket or the most exquisite urn or the most elaborate funeral to properly honor a loved one. And I don't know if you knew this, but you can supply your own casket or your own urn or your own container, whatever you want. And because of course it does, Costco has caskets. They have urns and they have flowers, and they're all at reasonable costs. And they will deliver your purchases to the funeral home within 2 days. Now, publishing obituaries in the newspapers or online, crazy expensive. They usually charge by the line, and you also have to pay extra to include a photo. So explore other ways of sharing information about your loved one. This is one of the few good things about social media, such as Facebook. When selecting flowers from a florist, try to avoid making selections from their funeral book or catalogs, because those tend to be more expensive. Because again, businesses know that we tend to spend more money when we're feeling emotional. And don't forget, Costco, good option. If your loved one is on hospice services, be sure to talk with a social worker if you're in financial need, because they can help you to make some arrangements. If your loved one's being cremated, all the ashes don't need to go into one container. You can ask that the ashes be separated into little bags or little containers, so more than one family member can have some, either for keeping or sprinkling at a later date. Be sure to save all of your receipts for funeral expenses. This includes receipts from Safeway for food for a reception, or printing costs from Kinko for the funeral programs. Because if your loved one was on Medi-Cal or received veterans benefits, these agencies will try to recover some of the funds that they paid out for care over the years. And funeral expenses are exempt from any recovery efforts. Now, I put together the slideshow for my mom's memorial service about a month before she passed away. If you've ever done a slideshow, you know how time-consuming it is. Some people thought I was very weird for doing this, but I have to tell you, doing it while my mom was still alive was a great way for me to process her life and prepare for her passing. Putting together a slideshow in advance, or even writing a tribute or an obituary, are tasks that you can also delegate to other family members. Remember, this is a stressful time, and be sure to take care of yourself before, during, and after. So I'd like to just read a quick passage from the NIA booklet that I've referenced a few times today. Caring for someone who is dying can be hard, and unless the death is unexpected and quick, there are choices to be made. These may not be easy. Planning ahead and working with the healthcare team can give you the support and help that you need to provide comfort. You will probably remember for a long time what you do for someone who's dying. Realize that this is a difficult time for you too. Being a caregiver for someone at the end of life can be physically and emotionally exhausting. In the end, accept that there may be no perfect death, just the best that you can do for the one that you love. And the pain of losing someone close to you may be softened a little because when you were needed, you did what you could. Now, unfortunately, many people mistakenly think that the actual funeral, the burial or the cremation, signals the official end of the period when it's acceptable to feel sad about the loss. The reality is that grief lasts, and it does not simply end immediately after the funeral or the service. And again, our July webinar is all about grief and loss. And so should you need to, I hope you're able to join us for that. Okay, this is my last slide. So funeral planning, both pre-need and otherwise, huge topic. It actually could be its own webinar. But I have some good resources for you on my list that I think you'll find helpful. The first two are from the California Department of Consumer Affairs Cemetery and Funeral Bureau. Yes, they have one of those. And then the purple one is from the Federal Trade Commission, because the FTC actually regulates funeral services. And if you're interested in funeral benefits from the Veterans Administration, which are excellent, by the way, I have a link on your resource list. And by the way, anytime you're looking for online information from the VA, make sure that the URL ends in .gov, because there's a lot of places out there that may misrepresent themselves as the VA.